Welcome everybody to today's session on cardiogenic shock. And the speaker today is Dr. Ramanathan sir. Sir is an adult cardiac intensivist, and he works as a senior consultant at National University Heart Center, Singapore. And he's also, director there of the fellowship program in cardiac intensive care. And he's also assistant professor of CT-based surgery at National University of Singapore and adjunct assistant professor at Bond University, Australia. And he's also the chair of ESLO Scientific Committee there in Singapore. So we thank Dr. Ramanathan for all his efforts. And I think it'll be great learning for all the audience, because cardiogenic shock is something we don't manage that well compared to septic shock. And moderating the session will be Sir, he's Professor Sandeep Mishra. He's a very well-known cardiologist in India, one of the luminaries, and he's the editor of the most prestigious Indian journal, the Indian Heart Journal. He's the editor-in-chief. And he was also my teacher during my residency days at AIIMS. And I thank him for all the teaching that he had imparted to me. It has gone a long way. Thank you, sir, for joining us, and we look forward to your valuable inputs. So I hand it over to Ramanathan, sir, to progress with the presentation.
Thanks, Tapesh, for that introduction. Good evening, everyone. My name is Ramanathan. People call me Ram for the ease of it. Today's talk will be on the management of cardiogenic shock. Now, I've stuck to the basics here based on Tapesh's request. So most of the slides pertain to the basic management of cardiogenic shock, the newer definitions or the newer approaches. The last few slides have dwelled on a bit of advanced management of shock and organizational aspects of cardiogenic shock teams. So without much ado, I'll just get started. Now, of course, Tapesh has told you much about me. So let's get started with the fact files of about cardiogenic shock. Why do we need to treat cardiogenic shock per se? Now, at the outset, we need to know that given the technology improvements, given our ability to diagnose cardiovascular problems early, intervention also happens early. And essentially, interventional cardiology has grown by leaps and bounds in the last few decades, to the point that we have now reached a stage where, in general, cardiovascular mortality rates has reduced quite significantly in the last decade or so. But having said that, we also need to know that a lot of, even though the overall mortality from cardiovascular disease has come down, patients who present in extremis, say those who present in cardiogenic shock, 50% of them still die. And 1 in 5 have hospital readmission within 30 days. So essentially, when we take one extreme of cardiovascular disease, which is the one in extremis, the outcomes are still poor, if not improving. Clearly, as I said earlier, early treatment has definitely shown that outcomes can be improved. However, we got to understand that in the last 20 years or so, death rate from cardiogenic shock has not changed in a big way. Now, this is despite the fact that we have the latest gadgets in town, despite the fact that our understanding of the disease has improved, and despite the fact that, the number of patients who have been vulnerable to this disease has been increasing. So essentially, all put together, our death rates have more or less been stagnant. More worrying is the fact that patients who have cardiogenic shock post-MI, and not only is their mortality, in-hospital mortality high, their mortality post-discharge from the hospital in the first 60 days is equally high. Plus, there is an increased risk of readmission within that period if they have had cardiogenic shock during a prior admission. So it goes on to say that, I'm just trying to put forward the gravity of the problem here and why we need to look at it differently despite having advanced things at our disposal. So there is definitely a need here to look at, not to just look at the outcomes, but to act towards improving it, especially with technology in our hands. Now, again, coming down to the basic pathophysiology and the consequences or the sequelae of cardiogenic shock. I mean, we all know that cardiogenic shock can be easily looked upon in 3 stages. So you have the initial compensated stage, then it progresses, and eventually it goes into an irreversible stage. Now, as it progresses through these various stages, you would get to see that the hemodynamic stability slowly comes down, or the patient becomes more unstable, and you get the metabolic sequelae of a failing heart. And that clearly is associated with a worsening mortality. So essentially, if you're going to capture your patient during the early compensated phase, you can do a lot of wonders. I mean, at least, you can prevent further progression of shock state, as well as you can reduce mortality. Now, a lot of these things, of course, I'm not putting the onus on us physicians. We also have to understand that there are other factors which will affect the presentation of your patient. So essentially, your patient with acute MI may not have immediate services or immediate, hospital services to attend to, and hence may reach you at a progressive stage or even an irreversible stage. So these are things beyond our control. However, given the fact that health services are improving rapidly and the fact that people are getting more educated about heart attacks and other important cardiovascular comorbidities or morbidities, it's equally important that, as physicians, we should aim to look at capturing these patients early, at least in the early compensated to the progressive stage, if we had to make a difference to the outcome, eventually what we're going to do. So I'm giving you so much of an introduction to the entire concept of cardiogenic shock here, mainly because I'm just trying to bring out those components which are treatable, the timelines where it's going to be crucial, where your interference or your intervention is going to be important. Now, having said that, patients with shock will need inotropes at some stage. And having said that, these patients with shock, as and when they need inotropes, they definitely would end up in the progressive stage of shock, which you saw earlier. And the more the number of inotropes they are going to be on, their hospital mortality is going to be worse. So as long as your patient presents with cardiogenic shock and you start them on low dose to moderate dose inotropes, you would still have a window of opportunity to intervene effectively. But the moment they go on high dose inotropes or to more inotropes, you will get to see that there is an exponential growth or exponential, there is an exponential curve of their mortality. And that is the reason why I'm saying this is again something which needs to be observed early during the patient presentation, and appropriate escalation of care should be done at the appropriate stage. So this escalation might be something in addition to the interventions these patients require for correcting their underlying etiology. They might need additional interventions, including mechanical cardiac support. And if your institution is not able to offer mechanical cardiac support, you might have to find out that window of opportunity to refer them to a higher institution. Mind you, the inotrope score or the rate at which you are delivering your inotropes can be a subtle or a surrogate marker of the severity of shock and an ability to reassess your resources so as to optimize therapy here. Now, as much as cardiac support in cardiogenic shock goes, there are 4 aspects that are going to be important here. Now, one, the management of shock state per se. The second, and the first and the foremost part, however, would be management of the underlying etiology. So in addition to the airway, breathing, circulation, things which we already do as part of ACLS, we'll have to make sure that the underlying etiology is identified early. Now in adults, most of the time, it's acute MI that leads to cardiogenic shock. However, you cannot have a tunnel vision thinking that this is always acute MI in every setting. You'll also have to start working up your patient to make sure that your underlying etiology is correctly diagnosed. Side by side or alongside with identifying the underlying etiology, you also will have to make sure what stage of shock your patient is in and what kind of therapy is required for that particular stage of shock. Now, I'll come to that in the next few slides as to how you identify this and how you initiate inotropes in such a setting. Now, there will be a group of patients who will be refractory to inotropes as well. And I'm here talking only about the management of cardiogenic shock. And such patients will require higher therapy or advanced therapy in the form of now, IABP or other mechanical cardiac support. Now, the evidence for each of this, I will present again, and we'll go through how these adjuncts can or cannot be useful based on evidence. Now, let's start off with a clinical case to make or to bring things into perspective. So let's say you have a 50-year-old gentleman who has acute MI, who presents with, let's say, chest pain and dyspnea to your emergency department. And essentially his initial ECG is unremarkable. But given that he's got ongoing chest pain and his BP is, his non-invasive blood pressure is low, he is brought to the CCU. You attach him to a monitor there, and this is what you get to see on the monitor. So these are the ECG traces. Your registrar manages to put in an art line, and you get to see an art trace which shows a BP of 80/50. Of course, fearing that this patient might need inotropes, the registrar also manages to put in a central venous line, shows a CVP reading of 23. Now let's ignore the rest of the waves here, except for the last one, which is saturation. And he is saturating 97% on 4 liters of nasal prongs. He's tachycardic too. Now, looking at this monitor, this is sometimes, of course, while now that he's got chest pain and your suspicions of acute MI is high, you would have definitely sent off your baseline investigations to make sure that, we rule out or we ascertain our initial diagnosis of acute MI. Now, while you're waiting for all these results, you clearly will have to manage his hemodynamics. And I think this is something which has to go side by side. Now, here is a patient who is tachycardic, hypotensive, and has a high JVP or a high CVP for that matter. All right. Now, classic triad, which makes you think whether this guy has cardiogenic shock. Now, what are the other important things that you can figure out from this monitor? Now, these may be subtle signs, which may be difficult to pick, but still, sometimes the patient monitor can be helpful in addition to a detailed clinical examination. Of course, I'm presuming that you would all have done your clinical examination properly and then be looking at the monitor while you await your results. One of the things that is quite prominent here is his arterial trace. Now, if you look at that arterial trace, this gentleman has what we call as pulsus alternans. So essentially, a sign of LV dysfunction. Clearly goes on to say that, following whatever the etiology of cardiogenic shock that has been, it has impacted on his LV function in one way or the other. Of course, these days we all do a bedside echo then and there to ascertain facts, but I'm still sticking to basics, and there are other ways of figuring out how stable your patient is. So what do you do next? Essentially, this is always the question. So one, you treat them for their symptoms. Two, you definitely, ascertain the underlying etiology. And then you look at the various important parts of the monitor whereby you can make a definitive diagnosis. And I always find the arterial trace a very good indicator of many of the underlying pathologies. Of course, again, this is all basic physiology. The arterial trace has an ionotropic component, which is characterized by the anacrotic rise. It has a dicrotic notch beyond which your diastole starts. So essentially, the area under the curve, if you draw a straight line from the dicrotic notch to the baseline, would represent your systolic BP and diastolic BP respectively. So the more the dicrotic notch is below, you got to understand that the patient definitely has problems with afterload too. So these are some of the basic aspects that you can gain from the arterial waveform. Of course, there are different waveforms associated with various other pathologies. I'm not going to go through this. These are all things which we would have learned as part of our medical curriculum anyway. However, I always find the arterial waveform to be quite useful in such scenarios, not only in just identifying if there is an underlying cardiac pathology, it also helps me in deciding fluid responsiveness if the patient is mechanically ventilated too, even in a patient with cardiogenic shock. So that takes us to the next thing that we are looking for. How do we classify shock state? So we've now seen this patient who has presented with hypotension and tachycardia. He clearly needs to be stratified now as to what therapy or what intervention he needs to be done. In addition to the definitive therapy, maybe he may need to be rushed to the cath lab if there is worsening chest pain, or if his ECG shows evidences of ST elevation MI. So apart from the basic things that we do, what else do we need to do in such a scenario? We need to stratify cardiogenic shock. And that's where, the SCAI definition or the consensus statement on the classification of cardiogenic shock is very helpful. Essentially, it's a very nice bedside tool to know about, where they talk about 5 stratifications of cardiogenic shock, which starts with a patient who is at risk, who has a beginning of cardiogenic shock, who has classic cardiogenic shock, who is in doom or who is rather deteriorating. And the last patient is the one who is in extremis, who is almost on the verge, or who has ongoing CPR. Now, what do each of these strata say? So SCAI class A identifies that patient who is at risk, who doesn't have any symptoms or signs of cardiogenic shock, but he's at risk for developing of cardiogenic shock. Now, these are the patients who have otherwise what we call a stable MI or stable acute heart failure. Now, these patients definitely need to be monitored closely. And they, as I said, can develop cardiogenic shock. And when they move to stage B or stage C, they start showing signs and symptoms. Now, these are the patients who would have hypotension and tachycardia. Now, they may have features of hypoperfusion, such as a raised lactate or a reduction in urine output. And our patient whom we just mentioned about would fall into one of these categories. Essentially, he would more be in category B than of category C till we get to see further of his results. Now, once the patient goes into classic cardiogenic shock, he definitely manifests with signs of hypoperfusion. And this hypoperfusion will definitely need intervention. So it is this stage where we are looking at further interventions like use of inotropes or mechanical cardiac support, in addition to, say, judicious volume resuscitation. Now, most of our patients get better with intervention at this stage. A subset of these patients do deteriorate. Of course, they deteriorate either because our initial interventions like inotropes don't work, or they deteriorate even after going on mechanical cardiac support. Now, those are the patients who go on to stage D or stage E. So essentially, as a bedside clinician, when I deal with a patient with cardiogenic shock, this particular consensus statement helps me in many ways. One, it helps me in deciding at what stage should I start proper intervention, and what all do I need to monitor at the various stages. To explain more about these 5 stages, I've already given you some of the things about the pyramid, the SEAI pyramid that stratifies cardiogenic shock. Now, this slide highlights what happens in each of these stages. As I said earlier, stage A is essentially normal. Stage B, where there is beginning of cardiogenic shock, you may get to see hypotension or tachycardia. The JVP would be raised. You would get to see the patients. When I say hypotension, you still need to define it for the sake of cardiogenic shock. It's usually defined as a systolic BP of less than 90 or a MAP less than 60, or a more than 30 millimeter drop from baseline. And as they move on to the classic cardiogenic shock, they also have evidence of organ hypoperfusion. Now, not only does the lactate rise, you would get to see that they get renal impairment or acute kidney injury. They get features of ischemic hepatitis. And as they deteriorate further, they essentially would need multiple inotropes or mechanical cardiac support to maintain perfusion. This stage is still considered as not a refractory shock. The moment they move on to the next stage, where they go on to extremis or where the heart stops, the stage becomes a refractory cardiac shock or cardiogenic shock. And this is usually, as I said earlier, associated with a cardiac collapse with need for CPR. The most intriguing thing, or the most difficult aspect that is very challenging to the bedside clinician in a patient who presents in shock state is the identification of what shock it is. Now, of course, our patient here had classic signs and symptoms of cardiogenic shock. So you would think that this patient has a predominant cardiogenic shock. However, you need to understand that there can be instances where patients can have varying presentations. They can have mixed shock states. So a patient with cardiogenic shock may have a side-by-side infection. Hence, they may have a mixed cardiogenic and septic shock. So it's not uncommon to see this in clinical practice. A few of these patients may have complications from MI. Say they may have a cardiac tamponade. So you may have a mixed cardiogenic and an obstructive shock in such individuals. So it's going to be important you also look for other sources or other causes of shock state while you treat patients with cardiogenic shock. A good bedside yardstick would be to look for whether their peripheral perfusion is good or bad. Usually, classic cardiogenic shock presents with cold, clammy peripheries. However, when you get, you can still get cardiogenic shock with warm peripheries when it is a mixed shock. And very often, if there is no cardiac or cardiogenic history and the patient is warm peripherally, you suspect more of a vasodilatory shock. However, these patients are still at risk of developing secondary cardiac events as part of their vasodilatory shock per se. So they can have a myocardial involvement secondary to their, say, septic shock or a distributive shock as well. So this is something which is very difficult in an acute presentation, and this might need time for you to figure out whether patients have a mixed shock or just cardiogenic shock. Of course, you can always have hemodynamic monitors to diagnose this more diligently. Of course, it all depends on the resources and the settings where you are as to how and what stage of shock and what kind of shock you're going to diagnose with the various modalities you have at your disposal. Now, I'm presenting the algorithm of the American College of Cardiology, which was published about 5 years back. The main reason I like this algorithm is because of two reasons. One, this was one of those first attempts, I would think. I mean, at least this particular edition, or this particular one, was more streamlined in that it defined cardiogenic shock better, and there was a stage of cardiogenic shock that was defined as pre-cardiogenic shock or early cardiogenic shock, and the definitions which till then were used at will became more streamlined with this particular publication. Clearly, I mean, definitely, that was one thing which this particular algorithm stratified. The next thing this algorithm stratified was the fact that they underlined the importance of a multidisciplinary team in the management of cardiogenic shock. This was one of those early attempts to bring out the importance of teamwork in the management of cardiogenic shock. So a cardiogenic shock team comprising of an interventional cardiologist, a surgeon, an intensivist would be very core, or would be essential to management of such patients. And even though it's a busy slide, this particular algorithm also underlined the importance of how you manage each stage of this shock, the importance of some of the mechanical cardiac support devices, and the timing at which you use them. So all these things were quite highlighted in this particular version of the algorithm. Now, one important thing that needs mention, and we did talk about it earlier, is in addition to the treatment of your primary inciting event, is the management of the shock states. And of course, management of cardiogenic shock can never be complete without talking about the inotropes. Now, you got to understand that you have a wide array of ionotropic agents at your disposal. At the outset, I got to tell you that I got to confess that there is no superiority of one ionotropic agent over the other. So if you were to ask me whether norepinephrine is better than epinephrine versus any other agent, of course there is, I mean, at least the head-to-head trials we've had so far have not shown superiority of one agent over the other. Goes on to say that any agent can be used in any cardiogenic shock state. But however, I wouldn't agree with that completely, because we know how most of these agents work. So essentially, an agent like norepinephrine, which has more peripheral vasoactivity, cannot be compared with, let us say, something like dobutamine or even epinephrine that has predominant ionotropic effect. But having said that, again, the use of vasoactive agents or ionotropes in cardiogenic shock is more or less institutional protocol based, given that the the evidence for one over the other doesn't exist. So essentially, very often you would find that in any peripheral center, they might prefer one of dopamine or norepinephrine as the first line agent in shock before, they move on to any other agent. I mean, you got to understand that, some of these agents are clearly predominantly beta predominant. So agents like dobutamine may be better off when it's used in cardiogenic shock. However, you got to understand that, dobutamine still remains an inodilator and hence may cause hypotension when the patient is already in shock state. So again, it's going to be managing the inotropy versus the afterload in a shock state. And essentially, sometimes you may not just use one agent, you might have to use a combination of agents as well. So sometimes dobutamine and noradrenaline might need to be added or might need to be run simultaneously so that the vasodilatory action of dobutamine is equally balanced by the norepinephrine. So the important thing I need to bring forward is the fact that even though, though I said that there are none of the RCTs have proven any superiority of any one inotrope agent over the other, the same thing holds good with societal guidelines as well. Essentially, if you look at the societal guidelines, none of them recommend a particular agent as the first line agent. Of course, they all recommend inotropes or vasopressors with the corresponding grade on the certainty of evidence. Everybody is, of course, all societies agree that inotropic support or vasopressor use definitely has a role in the management of cardiogenic shock. However, all societal guidelines would eventually boil this down to an individualized use. And I'm sure, as hospitals taking care of patients in cardiogenic shock, you all will have your own institutional protocols as to what agent you're going to start in your patient. As a broad guideline, I can say that when your cardiogenic shock has pump dysfunction, and it's predominantly a left ventricular pump dysfunction, so it's more of an LV failure that you're dealing with, I would think an inodilator like dobutamine for a start might be good. And countering the actions of dobutamine might sometimes be needed if the vasodilatation from dobutamine is in excess. You might have to sometimes use a combination of dobutamine noradrenaline if it's pure LV dysfunction. Now, if it is going to be a right ventricular dysfunction that's going to be predominant, of course, agents like milrinone can be helpful in the acute setting. Again, milrinone with noradrenaline is another combination that's predominantly right ventricular favorable in the event of a pump dysfunction. Now, mind you, one of the important things that happens hand in hand with pump dysfunction in a shock state is tissue hypoperfusion. So you would also need to address that, and judicious therapy with IV fluids would be required alongside management of ventricular dysfunction with inotropes. So this is something which can be broadly said about inotrope use in cardiogenic shock.
Should we kind of take a break, review the things, sir? Can we invite the comments, or you want to carry on from it?
Okay, yeah, we can stop here because the next few things are about mechanical cardiac support. So
yeah, because we're going on to mechanical support. So,
yeah.
MISHRA sir, would you like to make any comments on what we have covered so far?
Yeah, I think excellent presentation by Dr. Ram, and I think a lot of us have, got a very good view of what we are talking about and what to do. I made a presentation some time back, and many times actually in CSI, even in TCT, etc. So can I share parts of that presentation so that I think things can get more clear?
Sir,
I'll stop sharing here.
So we complete his presentation and then do your, or is that okay?
No, I'll just, because concerning his presentation, I will just show you a few slides that I've prepared, and that will, because I feel that will make things clearer. So please allow screen sharing. So coming to cardiogenic shock, as Dr. Ram said, actually there are three things that are very important in this particular field. One is the issue of oxygen supply by coronaries. So we talk of blood supply, but I will say oxygen supply because ultimately it's oxygen that is being supplied by coronary arteries, and that is determined by coronary diastolic blood pressure minus left ventricular and diastolic pressure. So the coronary diastolic pressure minus left ventricular and diastolic pressure gives us the blood flow through the coronaries and essentially oxygen supply by the coronaries. That is number one. Number two is what is the oxygen demand of the cardiac tissue. So I think that is the second important thing. And there we can talk of pressure volume loops. I don't think we'll go into details, but I will just show you small things so that you can understand what we are talking about. And finally, it is about the total perfusion or systemic perfusion, which is determined by cardiac power product, which is multiplication of cardiac output and mean blood pressure. So basically it is a some product of cardiac output and mean blood pressure. So let us see how these things, and all these three things are interlinked. So in a given cardiogenic shock, we have to determine whether the cause is predominantly decreased blood supply that is caused by coronaries, or it is because of increased oxygen demand by the coronaries, which can by the cardiac tissue, which can happen in certain times, especially heart failure. And finally, what is the cardiac output product and that is generated by heart. So these two things are very much important. Coming to myocardial oxygen delivery, I already told you it is a diastolic coronary blood pressure minus LV diastolic pressure, and that can also be impacted by lung disease and hemoglobin concentration because that is responsible for oxygen part. Talking about oxygen demand, the factors that contribute to increased oxygen demand are increased heart rate, increased contractility, increased preload, increased afterload, and muscle mass. So if any of these things happens, so for example, if there is some problem and there is tachycardia, so that will increase the myocardial oxygen demand, and that will cause us some problems. And then the third thing, as I said, is a product of cardiac output and mean blood pressure. So whenever cardiac output falls or whenever mean blood pressure will fall, the CPO will fall. And then I think you have to understand these two things are linked. Once perfusion decreases, let us say that when the blood flow through the coronary decreases, then cardiac output would decrease and left ventricular and diastolic pressure will increase. The effect will be, the overall effect will be fall in mean blood pressure. And once the mean blood pressure falls and there is increase in left ventricular and diastolic pressure, the perfusion pressure, which is mean coronary blood pressure minus LV and diastolic pressure, will fall, and therefore perfusion pressure will fall. So whenever heart function falls, the perfusion pressure also falls. This part we can see. Now the other thing is, whenever heart requirement increases, then whenever the PVA shifts to right, then the heart requirement increases, and therefore the work done by the heart will also start falling. And the third thing is that whenever the coronary perfusion falls, then what happens is once coronary perfusion falls, then cardiac function also drops. And when cardiac function also drops, then same thing happens. Then there is a further decrease in coronary perfusion pressure, and then a vicious cycle sets in. So whenever we are faced with the problem of cardiogenic shock, we have to look at two things. The problem is predominantly decreased coronary perfusion, which happens in heart attack, cardiogenic shock, and other situations, or whether it is decreased cardiac function per se, that can happen in heart failure or acute decompensated heart failure, where the predominant problem is actually a decreased cardiac function, and that leads to, in a vicious cycle, leads to decreased perfusion pressure. So having identified which is the predominant problem, I think we need to fix it. And therefore, whatever we are going to do will help fix this particular problem. So that is the first part that we have to do. We have to identify what is the cause of this vicious cycle. And then once we determine what is the cause, then we need to fix that cause, and that will help. So that is first part. The other part is that, as Dr. Ram also said, there is a very important issue with the timing of all these therapies. And it depends on what is our CPO, or the cardiac power product that I already talked to you. If the CPO is more than 1, we need to do nothing. But if CPO starts falling, I will just show you actually, once CPO starts falling, then there is a point where IABP will help. And then if it falls still further, if it falls less than 0.6, then IABP will not work, and we may need other cardiac assist devices. I will not talk about that right now. Let Dr. Ram show us the thing, and then I will come back to this and discuss these things. But what I wanted to tell you was that the window for any inotrope or any vasopressor is very early, before the CPO actually falls to less than 0.6. After the cardiac product output falls, then there is no benefit of using either these inotropes or vasopressors. So that is the point I wanted to make as of now. And let us see what Dr. Ram says. If there are any questions, then I think we can tackle them at this stage.
So we will take the questions at the end. There are no questions so far.
Okay.
Dr. Ram will continue with this presentation. Carry on, sir, Dr. Ram. Thank you.
Sure.
Slide.
Thanks, Dr. Mishra. That was clearly very nice. You clearly underlined the importance of sticking to basics and the rationale for why we make certain choices in cardiogenic shock. So to continue from where I stopped, so I stopped at the inotropes, and I think Dr. Mishra has clearly given that bridge for me to move on to talk about the mechanical cardiac support devices. And then he clearly mentioned the importance of measuring the cardiac power, or sorry, CPO, not cardiac, the power per se, the cardiac product output, essentially in cardiogenic shock, and how we can use it to our advantage in determining what advanced support we need to use. Now, again, these would be things that may not be possible in all hospitals. So, there will be limitation of resources, and there may be situations where, or there may be hospitals where, you may not have an adequate cath lab to do this. So essentially, you will have to decide on how you are going to manage your patient with cardiogenic shock based on the resources you have. So essentially, most of the patients with cardiogenic shock can be managed with inotropes in healthcare facilities with some basic care facilities. So essentially, with facilities good enough for resuscitation, you can manage patients with early cardiogenic shock. However, as I said earlier, the moment you move towards the progressive stage of shock, where your patient starts moving from stage C to stage D, where your inotropes starts increasing and the need for mechanical cardiac support comes in, the decision to do that, of course, in tertiary and quaternary cardiac centers, they have clear written algorithms based on right heart catheterization to decide on the kind of advanced cardiac support. However, in a less resourceful setting, you would find that when inotropes start increasing, or when you move from your first inotrope to the addition of a second inotrope clinically, and clinically you get to see that your patient is worsening, one of the things that most physicians resort to is the intra-aortic balloon pump. Of course, this was described way back in 1960, and there have been enough publications, including the IABP Shock 2 trial, which showed that in the context of acute MI cardiogenic shock, IABP does not reduce your mortality, nor does it impact on your catecholamine therapy or patient stability. However, you got to understand that despite all these negative evidences against IABP, IABP still continues to be the most common MCS device or temporary cardiac support device that's used in the context of MI. Of course, we know about all these evidences, but sometimes we may not have resources which may stabilize the patient immediately, and hospitals still or physicians still resort to IABP in this setting. So very often this happens when patients' inotrope requirements increase, and I'm just giving you the clinical cues so that you can decide on when such a support would be beneficial. Of course, as I said, the better way would be to do a right heart cath and base it on the CPO. But in a clinical scenario, you probably would use this immediately when your inotropes or when your shock becomes refractory to inotropes. Clearly, as I said earlier, there are a lot of studies that have shown lack of benefits with IABP, whether it's high-risk PCI, STEMI, AMI-CS, or even in the context of ECMO unloading, where the results are slightly different as compared to the rest of the cohort. We'll not talk about this, but at least evidence points otherwise, even though it still remains as the most commonly used temporary cardiac support device in a patient with cardiogenic shock refractory to inotropes. Its recommendation is only class 3B in patients with acute MI and cardiogenic shock. However, the utility of IABP is definitely there in patients who have concomitant mitral insufficiency or ventricular septal defect complicating MI. So these are the two major indications where it will definitely be worthwhile putting in a balloon pump in the context of MI. Now, in all other situations, evidence points otherwise, even though it remains quite commonly used. The other kinds of temporary cardiac support device that we tend to use in cardiogenic shock, apart from IABP, would be Impella, VA ECMO, or a hybrid where we use a mix of VA ECMO as well as Impella. Now, I'm not going into too much of detail about temporary cardiac support in cardiogenic shock here, because Tapesh had specifically told me to stick to the basics and mention these for completion's sake. So you need to understand that these devices these are advanced cardiac support devices that can be offered in tertiary or quaternary centers, and that can support the heart in cardiogenic shock. Again, the impact of each of these devices is quite variable. Of course, we do not have class 1 recommendations for any of these devices. Again, lot of things are still being unearthed, or we are still getting to see more evidence coming towards using them early in cardiogenic shock, and again with definitive indications. So you got to understand, I mean, at least for completion's sake, I got to tell you that when patients don't get better despite your inotropes, despite your IABP, then we move on to advanced cardiac support in cardiogenic shock. Now, to highlight some of the outcomes with each of these devices, let me start off with ECMO for cardiogenic shock acute MI. Again, there have been a very few studies that have shown outright benefit of VA ECMO in this scenario. Now, the main reason being, you got to understand that ECMO per se can support the heart up to a certain extent, but in a recovering heart, it's totally unphysiological. That's mainly because the ECMO pumps blood back into the aorta, and you got to understand that this pump blood flow goes against a beating heart. So essentially the beating heart, which ejects blood into the aorta, essentially is countered by the pump flow. So in effect, when you use VA ECMO in unison for the management of cardiogenic shock, you are essentially flogging a tired heart. And this becomes very important in the context of recovery. So subsequent studies, or studies that have been published of late, talk about the importance of LV unloading in such settings, whereby you unload the LV still with other devices while you use VA ECMO for peripheral tissue perfusion. Now, this is one of the best series from Paris, where they have shown that if you were to use VA ECMO for cardiogenic shock in a protocolized way, you can achieve as good as 45 to 50% ICU survival. Mind you, a lot of these patients not just survived ECMO, they were bridged on to LVADs or transplants at some point. The other device that we commonly use, or rather, that is hitting the news regularly, is the Impella device. Now, the good thing about the Impella device is it's placed inside the LV. It's an axial pump that takes blood out of the LV into the aorta directly. So in a way, it's physiological. So it unloads LV in all way. And some of the later versions or the higher versions of the Impella clearly provide end organ perfusion. Very often when you have cardiogenic shock in the context of MI, it's a transient or a temporary drop in your LV function. And at that point of time, the flows from Impella can help with end organ perfusion. And then we have Impella that can support just the right side of the heart in the event of right heart failure too. So again, these are costly devices. It has a lot of other side effects, or I would say, device related adverse events as well. So it all comes at a price. However, the logic behind using such devices is mainly to help the failing heart. Let me now move away from all these advanced cardiac support devices to another important concept in the management of cardiogenic shock. And this is something which is getting more and more popular, mainly because of the outcomes that we are getting to see with after such organization of shock teams. Now, I did present an early slide where I showed that the mortality after cardiogenic shock has more or less been around 40 to 50% in the past few decades, despite us having all the technical gadgets at our disposal. Now, one of the important things that has been or that is being addressed to improve outcomes in cardiogenic shock, and this is being done in most of the university hospitals as well as at the higher cardiac centers, is the formation of cardiogenic shock teams. Now, outcomes from the National Cardiogenic Shock Initiative, as well as few of the centers from US, have clearly shown improvement in mortality after shock teams were formed and protocolized management of cardiogenic shock was done. So, centers like Ottawa in Canada, mortality improved from 43 to 67%. So 2/3 of your patients who get cardiogenic shock survive, go back home. Essentially, that's something which is never heard of. The same thing with other centers as well, where they have shown significant improvement in mortality with clear-cut organization of the team for management of cardiogenic shock. This is one of those protocol templates that shows how a cardiogenic shock team works. So essentially, when you have a patient with suspected cardiogenic shock, you identify shock based on a certain clinical criteria. Mind you, there are international guidelines to say what those criteria can be, or you can have your own institutional criteria. And based on that, a shock team which is already present in the hospital gets activated. Now, as I said earlier, as per the earlier JACC algorithm, which highlighted the use of a multidisciplinary team here, the shock team essentially is a multidisciplinary team. The patient gets transferred to a definitive area where intervention and monitoring happens in addition to evaluation. And depending upon whether it's acute decompensated heart failure or other etiologies, the cardiogenic shock team then takes a call as to what would be needed for the patient at that point of time, and at what point further activation to advanced cardiac support would be needed. So essentially, based on certain, again, this is just a sample protocol or a template protocol. It can be variable within institutions, but most of the templates have the same kind of skeleton where decisions are based on a right heart catheterization and bedside echocardiography. Again, decision for percutaneous mechanical cardiac support is made on cardiac power output as well as measurement of cardiac index. So, if you go more into these organizational aspects, a shock team or a cardiogenic shock system of care essentially works at 3 levels, where you have a level 1 hospital that works 24/7, which is essentially a quaternary cardiac center that has all the advanced cardiac support, including ability for LVAD as well as transplant. And they run cardiogenic shock teams in spoke hospitals. So this is a hub and spoke model, which has been shown to be effective in the management of cardiogenic shock. Again, spoke hospitals can be a level 2 or a level 3 hospital. Again, level 3 hospitals may have only facilities to identify cardiogenic shock, support pharmacologically the cardiogenic shock, and any further intervention might need referral to a level 1 or a level 2 hospital where a 24/7 cath lab is available, and further advanced cardiac therapy might be possible in such hospitals. So again, organization of a system of care such as this, where you have a hub and spoke model, also helps improves outcomes in cardiogenic shock. Now at our heart center here, we do have a cardiogenic shock team. We do have our team essentially identifies patient in the ED. Of course, it's led by the cardiology senior resident or the consultant who sees the patient in the ED, classifies them as having a pre-cardiogenic shock or a cardiogenic shock. So that's the first kind of differentiation we get to do. once they get to know whether the patient is in pre-cardiogenic shock based on certain, important parameters, we have an algorithm that says, these are the things that need to be done. This patient can either be managed in the CCU or in the general ward, depending upon what stage of pre-cardiogenic shock they are in. And when they are being monitored closely, there will be a few other things which the primary team would follow up to make sure that they're not progressing to the shock state. And in case they progress to the shock state, or if the patient presents to the ED in the shock state, then there is immediate resuscitation, as well as there is notification of the rest of the team immediately on the spot, and essentially, activation of not just the cath lab, but also the ECMO teams, the Impella team, and the interventional cardiology team happens simultaneously. And essentially, it's a 3 or a 4-pronged approach to the deteriorating patient in the cath lab. So we all meet the patient, essentially all these individual specialities or specialists meet eventually in the cath lab, where the patient undergoes his first angiogram, and decisions are taken based on the state of shock, as I said earlier. So they usually will be in C, D, B, C, or D when they reach the cath lab. And based on what stage they are in, we decide on our intervention. So on the whole, I have covered a few basic aspects of the management of cardiogenic shock pertaining to where inotropes would be useful, where escalation of care to more than inotropes, say to mechanical cardiac support, would be needed, and at what stage would you do that? While you do that, how you stratify shock and take a decision on how you move forward. And eventually, when it comes to advanced shock state, you would definitely need temporary cardiac support to carry your patient through. So essentially, and I've also touched upon some of the important newer concepts that are coming up in the management of shock, things like formation of the shock team and how important it is in the course of a patient's journey in cardiogenic shock, and how it will make an impact on his or her outcome. I'll stop here, and I'm more than happy to take your questions. Thank you.
Thank you. Thank you, Dr. Ram. Very wonderful overview. And request Dr. Mishra, please stop the share screen, and request Dr. Mishra, sir, for his comments on cardiogenic shock as pertaining to our ICUs being managed by intensivists, Sir, Dr. Mishra, sir, please unmute yourself also. Yeah.
So I think I'm unmuted as well. So I think excellent presentation, and things are quite clear now. I think just to summarize what he said was that the first thing when you encounter cardiogenic shock is to determine what is the cause. So what is the etiology? Coming to cardiogenic shock, so far as cardiology is concerned, we have 3 important causes. One of them is, of course, advanced decompensated heart failure, and the other one is acute MI, and the third one could be myocarditis, and that sort of situation, or other causes, I would say. Now, the reason I say that this is the first thing to do is because if it is a cardiogenic shock related to acute MI, then the treatment is, as I said, 3 components. The first component is important, that there is decreased coronary blood flow. And that is the cause for the vicious cycle that has set in, that has ultimately led to cardiogenic shock or even pump failure. So the best treatment would be opening up of the artery. And at that stage, putting a device or even using inotropes or vasotropers will be just, secondary thing, or would be a peripheral thing. The main thing is to open up the artery. So that is why, what Dr. Nam also said, that, there are many trials which show that in MI cardiogenic shock, IABP failed to show any benefit. Even other devices did not show any benefit, for the simple reason that the predominant cause is basically blocked artery, and you need to open up the artery. You may take support with IABP. So thus IABP or Impella or other devices can support you for some time till you open up the artery. But if you are unable to open up the artery, then these devices will not work. So this is, I think, the first thing to make sure. The second thing is to identify whether it is a cardiogenic shock or other shock, for example, septic shock. And the way to do is if you look at CVP, or if you look at, if you do a catheterization, if you can look at pulmonary artery pressures, pulmonary wedge pressure, or pulmonary, we call it PAOP now, not pulmonary capillary wedge, which you previously used to call. But anyway, if you look at wedge, then if wedge is raised, then it is a cardiogenic shock. But if wedge is lower, and CVP might be 0 in a septic shock, or in a case where there is blood loss or volume loss, let us say severe diarrhea that causes hypovolemia and that causes shock, their CVP will be markedly reduced. But in cardiogenic shock, CVP will be markedly raised. So one thing is, if you can measure CVP, that is fine. If you don't measure CVP, the other thing that you can do is, if you have echocardiography in your ICU or CCU, you can look at the IVC, whether IVC is collapsed or whether IVC is full. If IVC is full, then the possibility of cardiogenic shock. If IVC is collapsed, then the possibility of the warm shock, or the either because of dehydration, or maybe because of blood loss, or maybe because of septic shock. So these things you can make out. So the second thing to make out is whether it is a cardiogenic shock or whether it is a septic shock. And the treatment of cardiogenic shock is different from septic shock. For septic shock, you use fluids, and you use basically vasopressors and not inotropes. Inotropes are something which stimulate heart. Vasopressors are something which increase peripheral vascular resistance. The commonest vasopressor, the best vasopressor to use is noradrenaline. The second best to use is dopamine. Now, Dr. Bansal just said that maybe he wants to know when to use noradrenaline, when to use dopamine. Now, remember, because noradrenaline acts predominantly on both alpha receptors and beta receptors. But because it acts on alpha receptors, it increases peripheral vascular resistance, and therefore it builds up the blood pressure. So in septic shock, because the peripheral vascular resistance is reduced, you need to increase peripheral vascular resistance, and therefore noradrenaline is the drug of choice. The other drug that you use is dopamine. How does dopamine act? Dopamine acts by releasing endogenous noradrenaline. So it does what noradrenaline does, but it does at all the other receptors and not at a single area because it increases endogenous noradrenaline, and at a high dose, it directly stimulates alpha receptor. So it could be a very good drug to add on to noradrenaline. And the third drug that you add on in case of septic shock is vasopressin, because vasopressin acts on vasopressin receptors, which has got an effect on alpha receptors. So again, these are the three drugs to be used. On the other hand, if it is a cardiogenic shock, then you need inotropes more than vasopressors. And therefore, dobutamine may be a good idea, but other inotropes like adrenaline also is inotrope because it acts also on beta-1 receptor more than other receptors. So adrenaline can be the second drug.
So if I may just interrupt here, ask you something. We have this, the drug of choice for both cardiogenic shock as well as septic shock is noradrenaline. Now in septic shock, at least we give very high doses, sometimes 30-40 mics per minute of noradrenaline. Then, like you said, we add vasopressin, and we are also supposed to add epinephrine. These are the three drugs which I use. Now the question here is, sir, which I would like to know, is that when norepinephrine is stopping to act, is there saturation of all the receptors, or is there not? Because they are acting through the same receptors. You are adding epinephrine to norepinephrine, they act through alpha and beta. Norepinephrine dose is going up, it is not acting. You add epinephrine, the effect comes. You get a constriction, vasoconstriction, blood pressure goes up. So how does this happen? If the norepinephrine has stopped acting, how can addition of epinephrine increase the blood pressure?
Okay. Good question. I will show you a table that I made some time back for an article. And can you see this particular table?
अभी तो ऐसा तो नहीं दिख रहा sir. You can't see.
You can't see? Somehow you are able to see or no? No.
It's very small. So maybe you can come closer.
Okay. So no, what I will say is that while adrenaline, while noradrenaline predominantly acts on alpha receptor, the action at alpha receptor is equal to beta 1 receptor, and which is more than beta 2 receptor. So what it means is that there is some action on beta 2 receptors as well. And beta 2 receptors are vasodilators. Remember, beta 2 receptors are vasodilators. So noradrenaline, while predominant effect is on alpha receptor, has milder effect on beta 2 receptor also, which is a vasodilator. So the problem is that if you add some other drugs which don't act on beta 2 receptors that much, then the act can be additive. So these drugs, they don't act on the same receptors to the same extent. They act on receptors to different extent. So even if noradrenaline has been fully active, what it will do is if you give topmost dose of noradrenaline, it will stimulate all the alpha receptors, but it will also stimulate beta 2 receptor. Now beta 2 receptor will act opposite of alpha receptor and will cause some vasodilatation. So the effect of noradrenaline will reach its peak, but because of its action on beta 2 receptors, some of the effect will be lost. If you add another drug, for example, if you add, let us say, dopamine. Now, what does dopamine do? Dopamine releases endogenous noradrenaline, but it directly acts on alpha receptor as well. So what will happen is that the effect on beta 2 receptor will be much less. And therefore, there will be some additive effect of adding dopamine to noradrenaline. The third thing is that the vasopressin acts on vasopressin receptor, and that has got direct effect on increasing peripheral vascular resistance as well. So beyond alpha receptor, it has got an effect on increasing peripheral vascular resistance. So please understand that if you add these drugs, then the effect overall is that there could be some more benefit beyond noradrenaline effect.
So it's an interplay of alpha and beta receptor activity.
Exactly. So because one thing counteracts other, and then it has got an additive role. If you add vasopressin, then even if all the alpha vectors are blocked, because it acts on vasopressin receptor, which also increases peripheral vascular resistance, it will have additive effect. Is it clear now?
Yes. So there is no different binding sites on the alpha and beta receptors. Same binding sites for norepinephrine, epinephrine.
They could be same, but the effect is different. Because
okay.
Yeah.
Okay. Then coming to a few more things, sir. Then what about the use in right heart failure? Dobutamine and milrinone as a pulmonary vasodilator and as an ionotrope. What about the use of vasopressin instead of noradrenaline to increase the blood pressure? Because vasopressin does not cause pulmonary vasoconstriction as opposed to noradrenaline. You used a pulmonary vasodilator like dobutamine and milrinone. That is an ionotropic act. It's a pulmonary vasodilator, but the blood pressure also falls, right? So you have to increase the systemic pressure. So for that, we can use norepinephrine. My question is, won't vasopressin be better? Because vasopressin is not a pulmonary vasoconstrictor, while norepinephrine is also a pulmonary vasoconstrictor.
Well, so now vasopressin acts predominantly on vasopressin receptor, and the effect on the alpha blockade is not that much. So you need a combination of effect. You require a lot of alpha stimulant effect to increase the peripheral vascular resistance. That will not happen with vasopressin. So that is why, if you have to use one drug, then this drug is good. But if its effect wanes off, then you need to add another drug, which can counteract some of the harmful effects of the other drugs. That's why we use in this particular way.
Tapish, to add on to what Dr. MISHRA was saying, the reason why we prefer noradrenaline along with milrinone than vasopressin is mainly because of its side effect profile. The side effect profile of vasopressin is stronger than of noradrenaline. People who have used vasopressin predominantly, you would hear them say that they would find more incidents of peripheral limb ischemia, gut ischemia as compared to NORAD. And of course, the other thing which favors noradrenaline is history. So essentially, noradrenaline has been used for a longer time than vasopressin, both of which promote using noradrenaline in the first instance along with milrinone rather than vasopressin.
Yeah, that's right, sir. But at the same time, given agree that the ischemia is more, but then one may consider that vasopressin does not restrict the pulmonary vessels, so cardiac output is going to be better, right ventricular cardiac output.
Yeah.
No trials comparing dobutamine plus norepinephrine plus versus dobutamine plus vasopressin in right ventricular failure.
Yeah, so theoretically you're right. Yeah, I'm not saying that you're wrong. Theoretically you're right, but when you initiate a therapy, you'll have to look at the risk-benefit ratio. So essentially, what risks you are subjecting the patient,
right, sir,
and what benefits he gets. So essentially,
right,
if you look at that risk-benefit ratio, there are good things about noradrenaline. One, it can be titrated in a much more mellower way. Vasopressin has only one dose, 2.4 units per kg per minute. While, with noradrenaline, you can titrate it right from 0.01 mics per kg per minute to say 0.2, 0.3. So you have that wide or a fine tuning of your peripheral vasoconstriction with NORAD as compared to vasopressin. So vasopressin, it's at one go. You can only do one dose.
Yeah, for shock due to variceal bleed, I think vasopressin is the drug of choice.
Yes. Okay, sir. Moving on to IABP. So I would just like your personal experiences with both Dr. Mishra sir and Dr. Ramanathan sir. Where do we stand with IABP in terms of in cardiogenic shock? MI coronary syndrome, fine. That is very clear. Do the revascularization, but there are patients with myocarditis, poisonings, and so forth. So where does IABP stand in terms of your personal experience?
Yeah.
Trials alone. Yes, sir.
Can I just share my screen once more? So what I will say is that if you look at this particular thing, you see that early on we use inotropes, but as the patient progresses down, then we start using IABP. At this point of time,
I will just like to interrupt. CPO, if you can define CPO for us.
CPO is cardiac power output or cardiac power product. So it is like it is a multiple. I will again show you. It's a factor that is a multiplication of cardiac output into mean blood pressure divided by 451. So basically a product of cardiac output and mean blood pressure. So this is the output of, this is the work power of the heart. It is the function of the heart. And therefore, when this work power starts falling, which means that is exactly what we are talking about in cardiogenic shock, this work power starts falling, and then you have to start therapies at a specific point. So in the beginning, you can start inotropes. That will help little bit, but as time moves on and patient does not benefit with inotropes, you have to put in an IBP. My personal experience is, excuse me, when used early and when used as a prophylactic agent, because for some cases of very high risk PCI, we even put prophylactic IABP. There it may be very useful, but the window of IABP is lost very soon. So once the patient progresses down this vicious cycle, and you can see that CPO keeps falling, and then reduced coronary perfusion also starts happening, then cardiac output and mean blood pressure even falls, and CPO falls below less than 0.53, then none of these therapy will work. And I will just come to actually this thing. So you can see that different devices are beneficial at different CPO levels. When initially inotropes may be useful, as the patient starts dropping pressures, then IABP may be useful for a very small window. But once that happens even further, then Impella or tandem heart is useful. If you put Impella for a long time, and I think Dr. Tapesh will agree to that, what Impella does is that it reduces the left LV unloading. It causes LV unloading. It decreases the left ventricular and diastolic pressure, and therefore the difference between coronary perfusion increases, because coronary perfusion is coronary end diastolic pressure minus LV end diastolic pressure. Once you unload the left ventricle, then coronary blood flow increases and then it helps. Likewise, IABP also slightly improves the coronary perfusion, and therefore early on IABP also helps. But if you put IABP late, when the patient has already advanced, there is no benefit of IABP. If you put Impella or tandem heart for a long time, what will happen is LV will be unloaded, but RV will start raising pressures, and the RV filling pressure will keep rising, and ultimately flow from RV to LV will stop happening. And that is where ECMO is very useful, because it can also cause RV unloading. Therefore, there are situations where both Impella and ECMO have been used to properly benefit the patient. So depending on the patient, I think we have to decide which device to use. I think it will be very detailed for most of our people here who are listening, but just to give them an overview that the devices help when given at the correct time. If you miss that window of opportunity, then these devices will not help. And
Right,
if, right?
Right. So I think this is a new concept, cardiac power output, product power output, right, sir? This is something we don't normally use and not familiar to us. Anyway, so moving on now, sir. Shall we move on, sir, Dr. Mishra, sir, or do you want?
Yes. No. It's okay. I just wanted to show you that you know.
Yeah. Point is taken, sir. It's a very nice slide, and this calculation of CPO will be helpful to us, I think. Then moving on, Dr. Ram, sir, would you like to just comment on a couple of things? The use of norepinephrine versus dopamine, because in cardiogenic shock and in septic shock, you know, the trials have clearly shown increased mortality with dopamine. So is that okay, as you know, norepinephrine as the vasopressor of choice for cardiogenic shock, or you said it has to be individualized? Because you know, literature clearly says norepinephrine is the drug of choice both for cardiogenic as well as for septic shock, and there is increased mortality with the dopamine. But you have said your personal experience and the fact about individualization in the institution.
Yeah, so there is something, again, you know, I find it interesting that way, because as I said, some of the head-on trials, say NORAD versus adrenaline, NORAD versus vasopressin, and you know, a few other trials as well, they have not shown any mortality difference between these agents. So if you were to ask me the evidence behind using inotropes in cardiogenic shock, well, the evidence points to no other agent, and that's clear with even societal guidelines. You know, they don't recommend one particular inotrope or vasopressor in cardiogenic shock. But if you ask me my preference, yes, I mean, I would still assess the heart, and if in a dire situation where I don't know what is happening, I'd prefer to start a low dose noradrenaline while I assess the heart with echocardiography, if possible, put in all the hemodynamic monitors, figure out, and then I tweak my inotropes thereafter. If it is a predominant LV dysfunction that I'm dealing with, then, you know, I'm talking about using an inodilator plus minus NORAD in that setting. If it is not, you know, I just, and if I'm dealing with septic shock, it'll be a predominant vasopressor that I'll be moving to. So the initial agent of choice when nothing is known, yeah, maybe NORAD in that particular setting. However, you know, in the first 3 to 4 hours, as the patient unravels himself and as you find out more about his etiology, I would change the inotropes if needed.
Right. So coming to some very basic questions, the diastolic slope in the arterial trace. You know, the diastolic slope is a reflection of the SVR. You know, if the SVR is high, it goes more slowly, slants slowly, and if it's septic shock, where the SVR is very low, falls rapidly, right? In cardiogenic shock, SVR is high, so it goes more, you know, slowly. So does this translate into meaningfulness at the bedside by looking at the monitor?
Yeah, look, I think, you know, the use of arterial line in shock state, we probably underuse the art line per se. I would think, you know, there are a lot of information from that arterial line trace if you pay attention to it. Essentially, mainly because, you know, we have other gadgets at our disposal which can give you a better idea. And these are, you know, basic clinical stuff that any graduate or a postgraduate should be good at while he's by the bedside. So, on any day, I would rely on bedside clinics than on any of these random number generators by the bedside. You can't rely on them. Sometimes they go wrong as well. But having said that, the arterial line trace, as you rightly said, it gives you a lot of information. And the position of the dicrotic notch is very useful in deciding early as to, where or what kind of shock you're dealing with. Mind you, there are a lot of caveats to that. People in old age, they will have change in their dichotomy. These important facts about arterial lines to your clinical advantage, but you should know about how to use them and what the caveats or limitations are while you interpret them. So otherwise, you'll end up like, it'll end up like how it happened with the PA catheter. So the PA catheter, when it came into vogue, there was so much of information coming out of it. A lot of physicians couldn't even interpret some of these information as to how it would be clinically useful. And essentially, they started taking in only the important bits and pieces from the PA catheter. So I feel, again, it's all a question of not just using the monitor wisely. You need to know the limitations of the monitor when you use it. And you need to, be aware of where it could go wrong.
Right, sir. Wonderful. So just a final couple of questions before we wind up, sir. Moving on to the right ventricle, cor pulmonale. So, unlike the LV, the RV behaves differently to volume loading, and, it's because of its altered geometry and the other features. When the LVDP is high, we don't give fluids. But in patients of acute cor pulmonale and chronic pulmonale, we have a different situation. So first, acute cor pulmonale, you have right ventricular infarct, and if there's hypotension, we can give them fluids. Okay, so that is one situation of right ventricular failure. Second is acute cor pulmonale, commonly caused by pulmonary embolism or ARDS per se on the ventilator. So in acute cor pulmonale, if there is hypotension going on, can we give fluids, and how do we decide? And then chronic cor pulmonale, if going into hypotension. Because the RV is responsive to fluids even if it is overloaded in terms of its pressure or volume. So is there a way about it? Or do we just look at the IV? The way I look at it is see the IVS. If the IVS is bulging, don't give the fluids. If the IVS is flat, give the fluids. Is there anything else, sir, you want to add to this in acute cor pulmonale with hypotension and chronic cor pulmonale with hypotension, giving fluids?
No, I agree with you. I think we look at the IVC, that's one. Other thing that you look at is also the wedge pressure or the CVP or the wedge pressure. So if wedge pressure is kind of low, then you are quite good giving the fluids. And often this thing happens that wedge pressure is low because it's predominantly right-sided failure, and you can't.
So we assume the left side is by and large okay, but yeah, even if you overload a failing RV, then that will lead to a decreased RV output. If you get the RV, if it's volume loaded or pressure loaded, like in cor pulmonale, acute or chronic, we are not talking about LV. LV is okay. But the right ventricular output, we have to optimize. Patient is in hypotension, he has acute or chronic cor pulmonale. How do you decide about fluids? I decide by looking at the IVS.
Yeah, me too. I think Dr. Tapesh, Dr.
Ramanathan, sir, any comments?
Something.
Yeah, I mean, look, Tapesh, one of the biggest clinical challenge that we face in a cardiac ICU is management of RV failure. There is essentially, it's one of those entities where outcomes can be very bad despite best of management, and it's also equally difficult to manage. As you rightly said, RV dysfunction per se, your initial or your textbook teaching is, if when you have an acute RV infarct, you fluid fill them and manage it. But at certain point, when it is an acute cor pulmonale, say in the context of PE, how much can you fluid fill them? That's a very difficult question to answer. And even with the most sophisticated machines you have by your bedside, it's not a straightforward answer, I would think. I think, I agree with your approach, and I also do something similar, where I look at the bedside echo, look at the position of the IV septum on the echocardiogram, and if it is a bulging IV septum towards the left ventricle, meaning to say that the RV cannot, work at all, then I don't give them fluid at all. I mean, and at that point, I stop fluid. That doesn't mean that I keep pumping in fluid injudiciously otherwise, but a good endpoint for that matter would be your IV septum. And also, having said that, the RV dysfunction correlates equally with other organ dysfunctions. You will get to see that your liver is slowly turning off, your urine output is slowly coming down, as well as your lactate is going up. Of course, these are non-specific, but then in the context of RV dysfunction, when you have all these things happening side by side, I think I would start cutting down fluid, giving fluids at that juncture.
Right, sir.
And I have to say that, just one more thing, I have to say that, giving dobutamine at this stage has been found to be very useful, especially, in context of right ventricular infarct. And we have seen those cases. Even biventricular pacing has helped in some of these cases. But I think those are advanced things. But dobutamine is something which you can add on to the fluid therapy.
Right. So I think, Vishal, if there are no more comments, just a few things from my side. One very important observation and my experience, I would like to add that to whatever has been said by our esteemed Dr. Ramanathan and MISHRA sir, that a very common cause of hypotension in the CCU is overzealous diuretics and ultrafiltration. Overzealous diuretics and ultrafiltration. I have been called several times from a medical intensive care unit to CCU to see a patient who has gone into hypertension. And I found that IVC was totally collapsed and he was dry because he has been given a lot of diuretics in the process of decongestion, or if he was on dialysis, a lot of fluid has been removed. So please remember, if you are seeing a patient with hypertension who has been receiving diuretics or has undergone dialysis with ultrafiltration, volume status can be very low at times. They just remove too much fluid sometimes because that is the way it is. The guy is in pulmonary edema and they remove a lot of fluid. So giving fluids to these patients brings up the blood pressure in such situations. So be aware of this situation also. It's not that all these patients are volume overloaded. And then finally, some very basic things about the arterial line. Whenever you are confronted with a situation of low blood pressure with an arterial line, make sure the arterial line is correct. It's giving you the correct blood pressure. A very, very important thing. In one major study, it was seen 20% of the times the arterial line was not giving the correct blood pressure. So please, the way about it is see the NIBP. If the two are giving the same, well and good. Flush the lines, do the flush test. Another thing is, where is the transducer? Just some very basic things which we don't see sometimes. We just see the blood pressure is 70/50 and there's a little bit of panic and do this, do that. So please ensure that the arterial line is giving the correct blood pressure. It is not at all uncommon. And if you have an NIBP in place, please also remember that the average cuff will give you a low blood pressure in a thin arm. If the patient's BMI is less or is emaciated or something like that, normal cuff will give you a low blood pressure in an arm which has a thin circumference. That also has to be taken into account. This is another fallacy. The blood pressure will always be 80/60, though it's supposed to be 100/70 or whatever. So you should know the correct blood pressure for your patient. Be cognizant of this. So I think I don't have anything more to add. It has been very well moderated by Dr. MISHRA sir and an excellent presentation by Dr. Ramanathan sir. He has taken a lot of time and beautiful slides and beautiful insights. Thank you. I think Dr. Ramanathan sir, is it okay? Do you want to add anything?
Nothing much, Tapish. Thanks for inviting me. Actually, it's been a nice talk. Actually, listening to all of you and sharing experiences. I really congratulate the kind of work you do, getting us all together on such a platform and allowing us or share our experiences. Attenks again.
Dr. MISHRA sir, anything finally you have to say, or should we close the session, sir?
No, I think it's a very good, attempt by you, and I think getting cardiologists and intensivists together is, I think, a very good thing, because we can always share our insights into many things. Thank you so much, and I mean, it helped me as well. So, Thank you so much.
Thank you, sir. Thank you very much. Thank you, and thank the audience for their patient hearing. Thank Ilores for their digital platform. Thank you, everyone.
Thank you very much. Thank you.